Thank you so much, Jackie. I'm a second-year CTN postdoctoral fellow under the supervision of Dr. Mona Lutfi. Today, I'm actually really excited to be speaking about my postdoctoral work thus far, which builds on the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, also known as CHIWOS. So I'd like to start off by acknowledging all the traditional territories on which we gather for this meeting. Today, I'm actually joining from Cambridge, Ontario, on the Haldimand Tract, so land that was promised to the Haudenosaunee of the Six Nations of the Grand River, and are within the territory of the Neutral, Anishinaabe, and Haudenosaunee's people. There is no conflict of interest to declare. Women living with HIV experience many barriers to care, which are heavily shaped by gender and intersect to increase women's vulnerability to HIV and STBBIs. So in response, my project builds on CHIWOS methods and practices to first examine perceived barriers to care for women living with HIV in Ontario, and second, to expand CHIWOS's national reach of the newly released Women-Centred HIV Care Model and Toolkit to the Maritime provinces, where little attention has been paid to women's health and social needs. So part one of my postdoctoral work involves applying geospatial technology to the barriers to care CHIWOS data set for the province of Ontario. It's the first use of this exploratory tool to study women's experiences living with HIV. An attempt is certainly going to be made to include all 1,422 participants, starting with the province of Ontario, as a way to further contribute to the understanding of the current state of care and well-being of women with HIV in Canada. So in order to be included in this analysis, participants must meet the following eligibility criteria. So they must provide the first three characters of their postal district, which is also known as a forward sortation area. And second, women living with HIV in Ontario must have responded to 50% or more of the barriers to care questions in the cohort questionnaire in order for me to create a visualization that adequately reflects barriers to care severity within postal districts. So I will now present to you the baseline CHIWOS survey data for Ontario. So we certainly recognize that women in CHIWOS surveys are gender and ethnically diverse. Of those enrolled in CHIWOS and living in Ontario, we see that 95% self-identified as cis women and 5% as trans and other gender identities. In terms of ethnicity, 32% self-identified as part of the ACB community, 39% as white, and 21% as Indigenous. From the following list of characteristics, you can see that women have high levels of education, yet low reported annual incomes. And this is in line with the larger cohort data from CHIWOS. Women living with HIV were also asked to describe their food situation in their household for the past 12 months. And they were asked the specific question here. In the past 12 months, you and other household members worried that food would run out before you got money to buy more. These results show that 67% of women in Ontario reported being food insecure in their lives. One specific study from CHIWOS found that experiences of concurrent food and housing insecurity were associated with factors such as low income, lower resilience, HIV-related stigma, as well as racial discrimination. There are a total of 66% of women living with HIV in Ontario who reported experiencing violence in adulthood and 58% as children. There are higher reported incidences of experienced violence as an adult and child in BC and Quebec than Ontario, respectively. The following figure provides you with an overview understanding of the severity of barriers to care among women living with HIV in Ontario from the cohort data sets of Waves 1 and Wave 2. Based on the responses of women, the 5 barriers to care with the highest reported severity, including absence of psychological support, inadequate or affordable housing, personal financial resources or financial instability, lack of job opportunities, and an unsatisfactory working environment. HIV stigma was also identified by women as being a large barrier to accessing care. One study from CHIWOS found that HIV and other forms of stigma have harmful effects on mental health, quality of life, and health outcomes such as testing, disclosure, and treatment. In terms of depressive symptoms, a total of 8% of women living with HIV in Ontario reported experiencing depressive symptoms most of the time. The results for feelings of depression in the Ontario sample is lower than that of BC and Quebec. Also, 80% of women living with HIV in Ontario reported experiencing depressive symptoms some of the time. The Canadian guideline recommendation states that women living with HIV should receive an annual Pap test after diagnosis. A total of 63% of women living with HIV in Ontario receive a Pap test annually, therefore meeting the Canadian guideline recommendations. And this accounts for 2/3 of all women living with HIV in the province. The most commonly reported reasons for not having a Pap smear in the past 12 months were not getting around to it, followed by not thinking it was necessary, disliking having the procedure done, my healthcare provider has never mentioned it, and fear. And this idea of fear included fear of pain, embarrassment, HIV disclosure, or finding something wrong. With respect to sexuality, 13% of women living with HIV in Ontario identified within the LGBTQ community. Nearly half of the women living with HIV in the Ontario CHIWOS dataset viewed sex as being a very important part of their lives. Social environments, this includes stigma and violence, have impacts on intimate aspects of women's lives. There may be higher rates of reported sexual inactivity among the women living with HIV in Ontario, yet 19% were still interested in becoming pregnant. Finally, most women living with HIV in both Ontario and CHIWOS groups were not comfortable talking about their reproductive health goals with healthcare providers. I feel that it would be interesting in seeing how this has changed over time in the cohorts Wave 2 and Wave 3 data sets, with greater discussions going on now around U equals U. So of the 713 women living with HIV in the province who enrolled in CHIWOS, 92% were linked to HIV care. Of those, 90% were retained in care and 80% were initiated on combined antiretroviral therapy. So the Kokurian article that I listed on the slide shows that attrition at linkage, retention, and ART initiation was mainly a consequence of social and physical determinants of health, and that barriers to current ART use, ART adherence, and viral suppression were consistent with structural inequities, and this includes stigma, violence, and incarceration. So these findings really shed light on key gaps, not only in the cascade among women living with HIV, but the barriers to accessing care within their communities. Another point of consideration is who is providing care to women living with HIV in Ontario. We found that 80% of women living with HIV receive their care solely from an infectious disease specialist, and this was also reflected in the BC and Quebec data. At a glance, you can see that there is a change over time in the reported severity of barriers to care among women living with HIV. In the more northern forward sortation areas of the Wave 1 data, you can see a higher reported rating of barriers to care, yet in the same forward sortation area in Wave 2 data, there's no severity reporting being made. So some explanations to explain this include migration in the province's areas where women living with HIV are not receiving care to more urban centers where they can. Second, there's loss to follow up in those who were actively participating in Wave 1. Third, there's participant death. And fourth, participant withdrawal from the study completely. So we're certainly going to learn more as we continue to work through this analysis of the data. Zooming into the Ontario map frame around Toronto, Hamilton, and Niagara Falls, we can see an increasing extent of severity of barriers to care reported over time. Preliminary findings show that experiencing HIV-related stigma, racial discrimination, depression, and a lack of social supports are associated with barriers to care in the province. And this is consistent with the larger literature supporting the effects of these characteristics on delayed access to HIV care and missed appointments, as well as other studies that are illustrating relationships between mental health and service utilization. We're continuing to analyze these correlates that are associated with barriers to care in the province. So the following visual shows the clustering points of population density for women living with HIV in Wave 1 data. Wave 2, I can let you know, does look very similar in terms of its distribution of population density as well. Most of the clustering points are found in Toronto, where 54% of all women in the province were recruited from. Given this region has the greatest numbers of enrollment and self-reported experiences of higher levels of perceived barriers to care, not only in Wave 1, but also Wave 2, it is of interest for further study that we carry on with this analysis. And then, of course, the inclusion of Wave 3 data. So part 2 of my postdoctoral work actually focuses on piloting the Women-Centred HIV Care Model and Toolkit in the Maritime provinces. We believe that the Women-Centred HIV Care Model may be a good fit for women in the Maritimes with the right adaptations, and that there certainly is a need for research to examine the health priorities of women living with HIV in the Maritimes, where little is really known about their realities and experiences of living with HIV in this part of the country. The objective of the pilot study is to assess the readiness for and feasibility of the Women-Centred HIV Care Model and Toolkit in the Maritimes among HIV care providers, community-based organizations, and women living with HIV. In terms of a working status update on this, our study is progressing slowly due to COVID-19. However, we do have plans to visit the Maritimes in the spring of 2021 to hopefully present both the model and the toolkit to our stakeholders for additional feedback. So the results of this project really serve to inform the need for a women-centered HIV care model. The first part of my postdoctoral work does show how relatively good HIV care is in Ontario. Finally, in terms of steps for part 1 of my postdoctoral work, I am planning to continue analysis of Wave 3 data set for Ontario and then to conduct multivariate logistic regression analysis for correlates with barriers to care to continue on building this narrative. I'd like to thank all of the women who participated in CHIWOS, my funder, the CTN, as well as my supervisor, Dr. Mona Lutfi, for her guidance and ongoing training, as well as all of the team members listed on the slide who were involved in my postdoctoral studies. Thank you.